Hi, welcome to Steps to Strides with me, Connor Ratcliffe, and today we're back in the garage gym looking at some potential loading strategies for the peroneals. And today's exercise is loop TheraBand Eversion. Now this is one of my favourite exercises. We'll take a look why. So first things first, we need to get our band set up around feet. If you've not got a looped band, you can use a straight band, just tie it off. And you get a reasonable amount of progression on a single band because we can just move our setup position. If we move our feet further away, abduct a little bit more, we get more resistance on the band. So you don't need tons and tons of resistance bands to progress this. It's easy for built-in progression. The important thing is that we do this one well, because it does lend itself to a few compensations, but that means that we can make it quite specific and we can make sure that we're actually getting our target structures, and we can train out some of those ingrained sort of neuromuscular patterns of compensation. So we'll go through how we want to do it first of all, and then we'll talk a little bit about why and some of the compensations and cues that we can consider to make sure we're getting best engagement of our target structures. In this case, more peroneus longus and brevis typically. So I will usually set up in this kind of position. If you can do it straight legged, but it does lend itself to a bit more compensation. So nice relaxed flexed knees, good. And what we're going to do is we're going to start with one foot on tension in an end range inverted position or in, and the other one is going to stay nice and neutral. So for the purposes of this setup, that's my right foot neutral, my left foot turned into end range inversion. So next thing we're going to do is we're going to point feet down, point toes down, or plantar flex foot and plantar flex digits. So this then becomes our start position, and I'm going to turn my left foot out just from the ankle, just moving the ankle, just moving the foot, and my right foot is going to resist being pulled in and just stay still. So it can become quite a neuromuscularly and cognitively complex movement because you are having to think about a few things all at once. So I'll typically get the patient to move through this range of motion first. So I'll act as a bit of a kinesthetic cue or do a little bit of proprioceptive neuromuscular facilitation with them. Fancy big words. And then I'll let them move through the resistance on their own. But this can sometimes actually just be a non-resistance movement, and then we'll add a light band and add resistance later on because we want our patients to do this well. So we'll then rinse and repeat on the other side. So now left foot points down, toes point down, and it stays neutral in frontal plane. Right foot comes in all the way, end range inversion, foot down, toes down, and then that one turns out to end range eversion. So if you need to modify this, because people have different tolerances of pain, again, your assessment will show this, and check out our assessment videos, but you can just modify the arc. So you can work from inverted to neutral, or you can work from neutral to everted. There's quite a lot of modifiability, which is one of the reasons I really like this, and you've got good control to be able to isolate structures. So if you do this in a bit more of a neutral position, or you bring them up into dorsiflexion, you're going to target a bit more tertius. But the other thing that you're going to kind of get more recruitment of, and you'll see it through digital dorsiflexion most of the time, is extensor digitorum longus, and it acts as an everter. It's quite commonly recruited, and you see this with extensor substitution in this movement, and that may or may not be an issue. There's good reason why people would do this, but if you just want to target peroneals and you don't want to overload extensor digitorum longus, or you think it might be a problem that it's engaging, and this position's tricky, that's why we get patients, or I would encourage my patients to point foot down, point toes down. That instantly makes it much easier to engage longus brevis because they're weak plantar flexors. So the other sort of things that you might see, apart from toes coming up, is legs turning out. So that's why we cue to just move the foot, just move from the ankle. So what we don't want is a load of this going on. And again, the more locked you are at knees, the easier it will be typically for patients to externally rotate whole leg. And that might be useful, but it's not just targeting the peroneals, which is what, we're aiming to do potentially. The other thing that you might see is that there's movement that way. So the patients start to abduct. And again, this starts engaging different muscles. So I'll get patients typically to put their hand on their thigh when they're undertaking this. So it becomes a bit more noticeable when they're not just using the ankle and when they're externally rotating. So it's quite a complex movement for what looks like a simple exercise and setup if we're going to do it well and we're going to get our specific target of our peroneals. So just to summarize and run through this one more time for what we don't want to happen. We don't necessarily want toes pulling up because then we're getting extensor digitorum longus. We don't want external rotation. We don't want abduction. What we do want is we want the foot to push down, toes to point down, because that helps with the engagement of peroneus longus and brevis, and it reciprocally inhibits extensor digitorum longus. Fancy big words. And then what we're going to do is one foot stays straight, one foot moves all the way through just from the ankle, just from the ankle. And if you're ever unsure, you can look for engagement. So we can look for a little bit of engagement in the peroneal muscle belly. We can look for engagement in the tendon, and we can feel for engagement. So that gives our patient something tangible as well to make sure that they're getting the engagement that they want at home, and it ensures that we can make sure that lateral compartment is engaging. So that's another potential option for peroneal loading strategies, which is looped TheraBand eversion.